Good evening, everyone. My name is Gloria Smith Cisse, and I am your moderator for this evening. And before we get started, I am going to ask Link Rhonda Mallory if she would give us a welcome.
Good evening. I am Rhonda Mallory, the Vice President of the Macon, Georgia chapter of the Links Incorporated. It's such an honor to welcome you to the Mental Health Awareness webinar. We're in partnership with Mental Health Awareness in Macon. Our theme, You're Not Alone, Support and Strategies for the Postpartum Depression. No matter where you are on your journey, mental health awareness is here for you. Since 1949, mental health awareness was established to serve communities near and far. Mental health has evolved into much more to help all of us. I'm looking forward to the great information of the panelists tonight. Thank you for joining us and enjoy what you hear. Thank you.
Thank you, Link Mallory, for that wonderful welcome. And I would like to welcome everyone too to this conversation on mental health. You are not alone. We offer some support and strategies for postpartum depression. Next, we're going to introduce or give each one of our panelists an opportunity to give us a little bit of information about themselves. And we'll start with Marana Craig. And if I mispronounce your name, please help me. I don't mean to. So we'll start with Miss Craig.
Thank you, everyone. It is an honor to be here tonight. The links and all the work that they do, and Ms. Cisse, with everything you do with Macon Mental Health Matters. It's just an honor to be in the room with all of you. So thank you for this opportunity. So I am Myrna Craig. I'm a licensed professional counselor and a master addictions counselor. I'm the director of enhanced behavioral health here in Macon, Georgia. I'm also the staff therapist for Wesleyan College and a treatment provider for Bibb County Accountability Courts and Peach County Accountability Courts. Today with me, I also have my intern, Tanika McKelvin, who will talk about her experience with postpartum depression. Thank you.
All right, thank you very much. Welcome, welcome. Next, we have Dr. Keisha Callins. You'll just introduce yourself, please.
Sure. Thank you, Ms. Cisse, and thanks to everyone that's joined us this evening. A special thank you to the Links for inviting me to be a part of this conversation. I am an OBGYN working here in Central Georgia with Community Healthcare Systems, which is a federally qualified health center network that's here in Central Georgia. We have 19 locations spanning through Macon areas. I'm actually in Gray today in Jones County, work also in Twiggs County, and just happy to be a part of the team that's able to provide services. Just real briefly, because we are a federally qualified health center, we can see patients that either have insurance, Medicare, Medicaid, or if they're uninsured. And we do have behavioral health providers as well that we can make referrals to, so wanted to share that information. But as an OBGYN for many, many, many years, it's such an honor to be able to work with women. I will share briefly that I really wanted to be a pediatrician for most of my life, and then I saw the light when I was in medical school, and I quickly figured out that when women dazzle, everybody shines. So anything that we can do to help women in terms of their physical health and mental health, it helps them, but it really has a ripple effect on their immediate family, their civic community, their church community, their work community. Everybody benefits when mom as well. And so really happy to be a part of the conversation today. And I believe I'm supposed to introduce my guest that I've invited as well. I think she's next on the screen. So I had the honor of meeting and sharing a panel discussion with Miss Ericalynn Cotton last week, Wednesday. We were both invited to attend a congressional briefing on maternal mortality at the US House of Representatives in DC. And she just really inspired me by her story, which she'll share a little bit tonight. And so I wanted to I actually called her today and said, can you join tonight? This is going to be awesome. And so she graciously agreed. And I think her story is powerful. She is a nurse. and has had some very interesting experiences, but I think she will also add a lot to our conversation. So she's coming to us from Philadelphia, but I think her story will resonate with everyone. And so I just wanted to say thank you for joining us tonight and hand the panel over to her.
Thank you, Ericalynn. Excuse me. Thank you, Dr. Callins. I was looking at Ericalynn's name and thinking, I can't wait to hear this story, and called your name instead. Did you want to add something, Ericalynn?
Nope, I think that was perfect. Dr. Callins said it all. I'll share more when it's my turn to speak.
Okay, wonderful. Thank you. I can't wait to hear. All right, Miss Pat Prime.
Good afternoon. My name is Patricia Prime. I am a registered nurse, a postpartum doula, and a lactation consultant. I provide support to families in the postpartum period. I have been working with moms and babies now for over 20 years. So there's not much that surprises me in the postpartum period, but that is also a period that is overlooked. And sometimes when we think about the postpartum period, we automatically go to depression or anxiety, but postpartum just means after birth. And so one of the things that I have done this year is to establish a nonprofit called It Takes a Village Maternal Health Expo, where we provide education and support around how the village, the community, can help keep families safe in the postpartum period. I'm excited to be here tonight and excited to be part of the discussion.
Thank you. What a powerful panel. I am so excited to hear what all of us have to add to this conversation tonight. So I'm gonna ask, there are a couple of questions. Actually, there are a few questions that we are gonna use to kind of guide our conversation this evening. And so they may be things that you already have prepared to talk about, or they may not, but they are some of the things that the ladies at Links wanted to know about. So I'm going to ask one, and everyone has an opportunity to speak to in whatever way they feel to the questions that we ask. So the first one is, how common is postpartum depression? How common is postpartum depression?
I believe that the statistics it is 1 in 7 women will experience postpartum depression. I have, let's see, I have another statistic for you. All right. See if I can pull that up over here. Hold on a second.
That sounds like a lot of women. It sounds
Yeah.
like a lot of women. Yeah.
So the statistic that I have shows that let's see. In the US, mental health conditions account for 28% of pregnancy-related deaths, 13.7% due to hemorrhage, so maternal deaths, right? And 12.8 cardiac conditions, 9.2 infection. So 23% of pregnancy-related deaths are due to mental health conditions.
That's a lot of people.
Yeah.
When I heard you say 1 in 7, I thought about, if there are 21 people who are sitting in this webinar this afternoon, at least 3 of them will have experienced postpartum depression. And I think when we kind of make it real, seem a little closer to real for people, they have an idea. So one in 7, it's like if we got 70 people, 10 of them may have had those kinds of experiences or may have experienced postpartum depression.
That's
All
right. I'm gonna give you one other statistic here. I
Okay.
see African Americans are 20% more likely to experience serious psychological distress, and Black women are half as likely to seek mental health care.
Mm. Those are both very interesting statistics. So twice as likely, but half to get the disorders, but half as likely to seek care, which I think is a really maybe it is a significant pointer for this conversation that we're having, because this is a conversation mostly among African American women. And when we start talking about these things, we can share this information with other women who will hopefully see the sense in or the necessity in seeking some form of mental health care. Thank you very much. Anyone else want to address that question?
I would only like to add, let's not forget our dads. I think
Yeah.
one in every
Yeah.
4 dads experience postpartum depression during that maternal incident. So part of what I do, taking care of the family, I'm not just completely focused on mom, I'm also focused on dad and our children, because they don't understand how to express their feelings and their emotions. I would not categorize them as having postpartum depression or anxiety, but they do also go through a transition during that maternal phase too. So that's why it's important to focus on the postpartum family after the birth of a baby.
Very good information. Very good information. We do oftentimes forget about dads and how important how pregnancy impacts their mental health, their physical health, their well-being as well. So thank you for bringing that up. And even more, we're even more less inclined, we're even less inclined to think about how it impacts the children who are in that family, the developing fetus, while mom is, and I know we're talking about postpartum depression, but sometimes moms start to feel those depressive symptoms before they deliver. And so we know sometimes that that developing fetus can also be impacted. And so, but definitely the children who see mom unhappy, dad unhappy, and not being able to figure out what to do are impacted. So thank you very much. I think I saw Dr. Callins turn on her microphone. Go right ahead.
Yes, I actually love those last few comments that you made. It's a perfect bridge into what I wanted to add to the conversation. And so I second Mirana. Am I saying your name correctly? Is it Mirana?
Myrna.
Myrna. And Patricia, who I know, and then Myrna is going to be my new friend. So I want to add that the term that we're starting to use a lot now is actually perinatal, because just like you said, a lot of things are presenting before. And sometimes it is a lot of times situational, because things have happened during the pregnancy and they kind of spill over or run over. But also want to talk a little bit about the spectrum. I know the focus of our conversation tonight is on postpartum depression, but there's a spectrum. So there are postpartum blues, and the other end of that is postpartum psychosis. And so there's really a range of things that can happen in that perinatal period. And so it's really important to be aware of how pregnancy can exacerbate some of those symptoms. And in a few rare cases, people actually sometimes even feel better when they're pregnant, because their motivation for what they're doing also is different. So it actually is not always a completely negative thing. Sometimes we see a boost and then things get back to their baseline. And so just being aware of that. I'm sure we'll get into this a little bit later, and I don't have any statistics to share per se, but I do know that there are a lot of women who have pre-existing mental health conditions and may either not want to get pregnant because they think it's not a good idea to do that, or they may starve themselves of the appropriate treatment or medications because they think it's going to harm the baby. And so I'm going to put an early plug in for the importance of preconception care, where we're able to work with our patients to say, okay, if you want to get pregnant, this is the medicine that will work well for you and not be harmful to your unborn child. And so being able to have access to that information, I think sometimes allows patients who have concerns to address them early, and so they don't get worse postpartum. And so being able to have that communication, but a lot of times patients talk, or we talk ourselves out of things that could be helpful because we're worried about harming that baby. But we do have a lot of good research, and there are lots of cases where, prioritizing the health of mom is exceptionally important in order for us to have a healthy baby. And I will tell you, I have one story that I will never forget. So labor and delivery, we had a patient who came in who had been in an institution, and the cords that the cables that we used to monitor baby, she had wrapped them around her neck and tried to strangle herself in the hospital. And so there are things that can happen. And so how we address what happens in pregnancy absolutely sets us up sometimes for how well we can help moms transition with that after that baby's born. So that's my 2 cents on that.
Wonderful 2 cents. Wonderful, wonderful. And it caused me to think about, the issue of equity, right? And how is equitable care being provided to moms who are part of the BIPOC community, and how often might they not have an opportunity to speak with a doctor during that perinatal phase around, the appropriateness of continuing their medication while they are are pregnant and expecting their new child. So this is already a wonderful conversation. Wonderful, wonderful.
I wanted to invite Ericalynn. Maybe this is a good time for her to share her story that really touched me with her pregnancy. And so she's gonna give you a little bit, and if you have tissue, you probably want to get it out. But Ericalynn, you might want to.
Go right ahead, Ericalynn.
Good evening, everyone. I am Ericalynn Cotton. I am a women's health registered nurse and also the founder of Beauty Over Ashes. Last week, Dr. Callins and I met each other during a briefing about Black maternal health with the emphasis of mortality, and we talked about hemorrhage. But today, because this is specifically for mental health, I'll share a little bit extra of my story that is in the realm of mental health. And a lot of things were actually mentioned already. So I'm sitting here with my pen like, oh, I have to make sure that I mention this. And so my story is unique in the sense that I am a nurse. So I did have certain information when I was delivering. And I'm also I did a lot of research and things like that. And so my gynecological history is as such. I have fibroids and endometriosis, and I didn't find out that I had endometriosis until I was in my 30s. I got married at 21, but we didn't want to have children right away. So I was around 28 or 29, and we were trying to figure out what exactly was going on other than the fibroids, and I was diagnosed with endometriosis. I had the surgery on the endometriosis, and they found that there was some blockages in my tubes that they had to clear out, and then I was able to become pregnant. I also had 2 losses prior to that. So I had a loss in like 2007, and then I also had a loss in like 2017. They were both first trimester losses. So when I get pregnant the 3rd time with my now daughter, I had a lot of anxiety already just surrounding pregnancy. So now as a nurse, I know you have fibroids, you have endometriosis. So you're already at high risk, right? You may deliver early. And then also you have a history of these first trimester losses. So my whole pregnancy, I was anxious. Every cramp I got, I never had any spotting, but every time I would cramp or have like severe pain working 12-hour shifts at the hospital, I was just very anxious and very nervous. So much so, nobody even knew I was pregnant. The only reason why people at the hospital, my coworkers, found out I was pregnant was because one day I had a TB patient, and I was like, oh, it's fine, I'll take the patient. And they're like, one of my friends knew I was pregnant. She's like, you're pregnant, you can't take that patient. And I'm like, I don't want anybody to know, because I was so nervous that I would lose my baby that I would rather wait to deliver for anybody to find out, especially working on labor and delivery, where to the general population, losing a baby seems like it's something that's not very common, something that doesn't happen often. I worked in one of the largest delivering hospitals in Philadelphia. So we had what's the best way to not use it in a medical sense? We had like people lose their babies internally, like either before they delivered or immediately after delivering at least once a shift. So for me, I saw it quite often. So this was another fear of mine that aided in the anxiety that I had. When I was 17 weeks pregnant, I went to the hospital in excruciating pain. I had ovarian torsion, and they were going to have to do emergency surgery. And I remember one of my coworkers, and this is a coworker. So this goes to the point of, as providers, you just have to be really careful with how you talk to and treat patients, because she was one of my coworkers. She was a nurse, and she was like, "Oh, it's fine. We'll just take one tube. People get pregnant with one tube all the time." And they're like, "Just try again." And I'm like, oh my goodness, like that's such an insensitive thing to say. And long story short, one of the other doctors ended up reading the report, and it wasn't a torsion. So there was slow blood flow, not no blood flow. So they ended up monitoring me, and I ended up not having to have the surgery. And that was at 17 weeks pregnant. So I continued the pregnancy. I was under the care of a midwife and maternal fetal medicine because I was high risk. And I was so anxious about losing my baby the entire time that I never thought that I would lose my husband. So when I was 7 months pregnant, my husband died. He died from a thromboembolism. We were supposed to go out on a date. He was a comic. He never came home. And we ended up discovering that he had passed away in his car with a thromboembolism. So here I am, 7 months pregnant with this baby that we tried for so many years. At this point, we had been married for almost 10 years together, for about 15 years. And all he ever wanted was to be a dad. All he ever wanted was a family. And so I'm finally pregnant. I'm 7 months. And that's how everybody found out we were pregnant. He was a famous comedian in this area. And so the news title went like, Chris Cotton, comedian, dies at 32, leaves behind pregnant wife. That's how everyone found out. And so, of course, I had a history of depression already. I was already anxious the entire pregnancy. And my midwife was like, listen, you need to make sure that you're able to talk to somebody, because to the point that was said earlier, I am pregnant with this baby, and she can feel every single emotion, all the chemical things that are going inside my body because of this loss, because of this devastation, because of this trauma. She also is now feeling it. And so I ended up delivering her. I had a postpartum hemorrhage. 200 of my lost blood, my blood that was lost was from my uterus, and then the other 350 was from a vaginal tear. So I had two different types of vaginal tears. And one of the things that contributed to the vaginal tear was the fact that I had poor skin integrity. Poor skin integrity a lot of times comes from people who are not malnourished. And so one thing we thought about was my mental health, right? Like your husband dies, of course you need therapy. We thought about that. What we didn't really consider was like, you probably aren't eating and getting the nutrients that you need because of this depression, because of all of the things that are going on. And so I had poor skin integrity. Every time they went to suture me up, the sutures just kept, like, my skin just was not like strong enough to hold the sutures. So getting the repair done actually took longer than it did for me to actually deliver my baby. And so just through that experience, I realized that it's very important for the healthcare team to see the person as a person, right? And the whole person. So you have this pregnant woman, but you have all these outside factors that may be happening. Now, my situation is a very obvious one. It's like this woman is pregnant and she has two losses. So she may be anxious about, keeping this baby. And also now she experiences this trauma. But sometimes there are stressors, like maybe this woman has to work, a double every single day to provide for her family, or maybe she has 4 kids at home and it's just maybe the father is present, but there are so many different things that contribute to the stress level of a woman. And given the statistics that we heard about the stressors that we experience, the fact that we experience depression and we don't talk to therapists, I think it's very important to keep those things in mind when creating the relationship between a provider, a pregnant woman, and their healthcare team. And so that's a little bit about my journey with depression, anxiety, and postpartum hemorrhage.
Thank you very much for that story. What a powerful story. I didn't grab my tissues, but my heart was aching. So I'm really, really proud of the fact that you're still here and you have your daughter. Yeah. How old is she now?
She's 4.
Oh,
So
okay.
she turned 4 in February. Oh, and I did want to add as well, given the experience that I had with losing my husband while I was 30, I realized that there weren't many resources for young widows. When you think of the word widow, you think of someone who has grandchildren and, a whole lot have lived a whole life. And so I started an organization called Beauty Over Ashes, and we specifically support men and women who are at the early stages of raising a family. So whether it's a woman who was pregnant, who lost their partner, or we know that Black women die, are higher likelihood of dying during childbirth. So then what's that father to do, right? And so we created an organization where we provide doula services. We provide, because I had a postpartum doula as well, and didn't realize how important they were until I had my daughter and had the loss of the support of my husband. And so we provide doula support, we provide mental health resources, we provide baby essentials, and everything is free to the participant. The provider or family member calls me, or the organization lets us know what the need is, and then we provide those things for free to the woman or man. And so I created a slew of resources that were helpful for me while going through the journey that I realized was not readily accessible and has not been. And so I wanted to be the answer to that problem.
Very good, very good. And maybe we could put that information, somebody could put it in the chat so that we won't lose it. And I was listening to you, I thought about the significance of us understanding that much of the things that moms experience during the perinatal phase, their babies also experience. And so and how important it is for us to nurture mom's physical and mental health in a way that, that also nurtures her unborn child or her newborn's mental health, mental and physical health. Thank you so much for being willing to share your story with us today. Thank you, Dr. Callins, for inviting her to join us. That is powerful testament to all the work that we need to get done, right? As women, as professionals, mental health and physical health professionals in this community, well, across the globe, really. I have another question that may be slightly related to what we just talked about. And this question is, are there certain demographics or risk factors that make women more susceptible to PPD? And
Yes.
we thank you, Pat, for bringing men into this, but is there something that makes women more susceptible? And
I would love to answer that.
okay.
I got my statistics over here again. All right, so who's at risk? So if you have a pre-existing mental health condition, right? And younger mothers age 25 or below, if you experience gender-based violence, if you experience intimate partner violence, if you have unfavorable social determinants of health, a lack of social resources, and women with adverse childhood experiences, that ACE score. So, and adverse childhood experiences have 3 categories: abuse, which is physical, emotional, or sexual abuse; neglect, which is physical and emotional neglect; and household dysfunction. So mental illness, incarcerated relative, mother treated violently, divorce, or substance abuse. So these are women who, in childhood, experience this in their household.
Again, the impact of what happens to mom happens to their children. I don't know if any of you ever heard of, oh gosh, she coined the term infant mental health. And I'll remember her name when we start talking about something else, but she talks about the significance of how moms transfer unconsciously their mental illnesses or their mental health concerns to their infants. And I think it was Pat I heard say something about the village, but it is so important, y'all, that all of us wrap our arms, our minds, whatever we have, our resources around the women in our community who are having, and men, I don't want to say not men, women and men who are nurturing our next generation of people. Did anybody else want to address that the demographics or risk factors of why women are more susceptible?
I just wanted to add briefly that I think every one of us could fall into one of those categories in some shape or form. And so it's important to realize that we're technically all at risk, but then there are some of our patients who will have multiple layers of those things. But the key point I want to share is the importance of being able to have your patient feel comfortable enough to share that with you. I had a patient last week that I saw, and I forgot what we were talking about. She was talking about her kids being in Virginia, and then she was in this different place. And it just kind of, as we talked, she ended up sharing she was living in a shelter, and she had a domestic violence situation, and he actually tried to kill her with a gun. But she didn't say that when I walked in the room, nor was that shared with the nurse that did the triage. And so the importance of providers making patients feel comfortable to share the ugly part of what they don't like, or moms postpartum. It doesn't sound good because you're supposed to be happy when you have a baby, right? But what if the baby is crying all the time and they're colicky and you don't feel good? So how do you get your mom to verbalize that thing so that you can then address it? Because a lot of the cases that we see, we wonder, well, did anybody know or recognize that? And so I think it's important for the healthcare team and the caregiver team and the support system to recognize they're not answering their phone, they're not getting out of the bed, they haven't taken a shower, or they're snappy. I call it the snappy turtle syndrome. I ask them, does your husband get on your nerves? They should to some degree, but if they then say, well, I feel like everything everybody says irritates me, and that's kind of a flag, and that's an opportunity for a conversation. Ericalynn, we see your baby girl, your precious miracle back there. But I think that in order for us to get those risk factors, patients have to be comfortable. We have to be able to connect so that way we know what the problem is, and then we can offer resources. But there are a lot of people walking around with things, and I cannot tell you how many times if I didn't keep probing or notice something or a bruise here or there, I may not have extracted that information. It's not because you're not taking good history, but people don't want to tell you their ugly thoughts, So I see a postpartum mom and I'll say jokingly, do you feel like hurting your partner? They should say yes, because you're annoyed and you had a baby and you don't feel good and your private's hurt. And then I'll say, do you feel like throwing your baby out the window? They should laugh and not react to that. But every now and then I get silence. And then that's an opportunity. So creating an environment for people to share all of those things that you mentioned is extremely important, because there's so many people walking around with those burdens, and they don't know, as Patricia mentioned, that the village can help them with that. They're carrying that backpack with everything. And so we have to create a space where it's okay to ask for help. It's okay to put a life jacket on for a few minutes so you can rest and you're not tired from swimming. And that's really important for us to do as providers, but also as a community and as a village, as Patricia mentioned.
Definitely important. Go ahead, Patricia.
And I would thank you for bringing those points up, Dr. Callins. As a postpartum doula, I come with no judgment. And so every maternal patient or family has a background, and their family or their village knows them way better than I do. So we're taught as women to just, put your big girl pants on and go do what you need to do. And because that's something that's been passed down, when a woman is going through something in her home, in that maternal phase, they think something must be wrong with me because I've never heard anybody else have this issue. So the more we keep stuff in, the more women continue to struggle. Because I come with no judgment, I don't know the mom's history. I'm only looking at the symptoms that are in front of me. So one example would be, I just saw a mom and I'm seeing her for lactation support because I've been doing this for 20 years. Some things are just kind of automatic for me, and I can tell, I can recognize anxiety. I can recognize a person that's having a depressive state or just not having a good day. And the second time that I go to see this mom, we were sitting in the dark, but I could see the tear roll down her cheek from the sun. We were sitting uh, opposite each other. And she's complaining, not complaining, but telling me that the baby gets mad and that she turns red and she's not understanding why the baby is so angry. And then she says, I'm over it. I'm tired of her, or I'm done with her, something to that effect. Because of my role and some of the things that I can do to help support this mom, I don't just jump and say and say I'm gonna call 911. I know some of the things to ask. I know kind of how to take this conversation. This is only my second visit with this mom, though. So this visit went from being an hour visit to like a 3.5 hour long visit. But I found out during this visit that this mom had a history of mental illness. She had been hospitalized. She had been on medication. There was issues between her and her mom. Like, I found out so much more about what was really going on. And I'm only coming in because she wanted breastfeeding support. So as a postpartum doula, I have found in this community, either people are not aware of what doulas are, they're not aware that in the postpartum period, it's important for us to make sure that mom or that family is okay, because both of these people work from home. Dad is in the next room, literally the next room, with his headphones on. So when I walk in, he lets me in. They have a lot of like the house is electronic, the doorbell rings, but I guess the light flickers, and so they know that the doorbell, that kind of house. Like I was getting ready to cook her some food. I put some food in the microwave to defrost, and he got a notice on his watch that something was in the microwave. Like, they have that talking house. But he was in the other room with his headphones on. So the baby was crying when I got there. I assumed mom was in the room taking care of the baby, but she was done with baby. And so while she and I were talking, the baby continued to cry. And finally, I realized Dad wasn't going to go get the baby. So I went and got the baby, and she instantly stopped crying. But the mom took that as, see how you can make her stop crying. I can't make her stop crying. All of that stuff could have been horrible had I not been invited into that space to provide lactation support. So today she's doing much better. I was thinking I was going to get hired as a postpartum doula to come in and provide support for them, and that still may happen. But the reason I'm bringing this up is because our moms are in these homes, and this is what they're struggling with. This is what they're dealing with: a crying baby. Like, they're dealing with, they can't take a shower. She had not eaten since the day before. So she's working on fumes. So in order for her to be able to put on the uniform that she needed to take care of that baby today, she had nothing. She was on fumes. So had I not gone to the house and Dad's with his headphones on, who knows what would have happened. that's why one of the things that's so important for me is teaching the village. If you know someone that had a baby, can you just call and make sure that they're okay? Can you just go wash their dishes? Can you just go, watch the baby for them while they take a shower? Can you just drop them some food off? We think that those things are not necessarily important, but those things are vital to a family that just had a baby. And I'm not talking about 2 days after they get home from the hospital. I'm talking 2 months, 3 months down the line.
And I would love to see, when we have our fancy baby showers, we go ahead and establish the food train, right? I mean, when I delivered both my kids, I was fortunate and I didn't have everybody come at the same time. I had my mom for 2 weeks, my mother-in-law for 2 weeks, my dad came for 2 weeks, like we had a rotation. And so, we spend a lot of time on the gender reveal, which is good, and planning the baby shower, but that's a sign-up sheet time for food and laundry and I need bath time or whatever that means. And so that's why I love your focus on the village because we have a responsibility to help take care of our moms. And I just put a bunch of things in the chat because when we think about postpartum depression, we need to think about that pregnancy loss, which you mentioned, because it's hard and I've had a couple of patients and close friends that have lost a baby. So they're depressed, they may start lactating and there is no baby. That's a whole nother level of depression. Also, unexpected events, preterm labor or preeclampsia, or you thought you were going to have a vaginal delivery, now you have a C-section, or you had a traumatic birth and you had postpartum hemorrhage. So they're like all these factors that you cannot predict for.
Mhm.
So how responsive can we be as the healthcare team and as the community to really help when things don't go well? And it's really important to realize that everybody needs help. At some point, in some form, everyone needs help. So I put some resources there for everyone to look at.
And it's
And I'd
really,
like to,
oh,
I'm
sorry, go
sorry.
ahead. Go ahead.
Okay, I was going to say, I'd like to say that those things that Dr. Callins mentioned, the things that occur during the pregnancy, health related, are traumatic, so that's trauma.
Mhm.
And a lot of times we don't realize that then now they're experiencing trauma because of these things that are happening within the pregnancy.
Form of medical trauma, exactly. And when we look and we see people through a trauma lens, it really changes the way that we are examining everything and everybody in all the environments that we work in. Okay, so the next question I have here, and this, I think I heard Dr. Callan or someone mention this earlier, but it has something to do with the key signs or symptoms of postpartum depression, and if there is a way to differentiate postpartum depression from the baby blues.
All right. I have actually, let me see if I can share my screen.
Mhm.
You guys.
Mhm.
All right, you're gonna have to help me. That's it, right?
Mhm.
Okay.
Yeah.
All right, and share. All right, so and we're gonna scroll up. Okay. And so I think that leads us to baby blues versus depression. And so you can, I hope you guys can see on the screen. I'll try to make it a little bit bigger. And I'm gonna read it as well. So we were looking for the symptoms, right?
Mhm.
Okay. So baby blues, common and temporary experience right after childbirth when a new mother may have sudden mood swings, feel very happy, then very sad, or cry for no reason. This is not considered a psychiatric illness. And so it usually occurs the first week after delivery. It peaks 3 to 5 days after delivery and usually resolves 10 to 12 days postpartum. Let's see. And so, here a little. And how long does it last? So we said up to 2 weeks. How often does the baby blues occur? It occurs in up to 85% of women. So that's most. um, and then what happens? You have this dysphoric mood, crying, mood lability, anxiety, sleeplessness, loss of appetite, irritability. Baby blues is a risk factor for postpartum depression. Okay. And so then we want to look at major depression or unipolar, as it's showing here. It's where a depressive episode occurs during pregnancy or within a year of giving birth. It most often occurs in the first 3 months postpartum, may also have started before pregnancy or begins during pregnancy, after weaning baby, or when the menstrual cycle resumes. All right, and so when we look at who's susceptible to depression postpartum, a personal history of depression or postpartum depression, family history of postpartum depression. So remember that a family history, so someone else in the family may have experienced it. Fetal newborn loss, a lack of personal community resources, substance use, addiction, complications of pregnancy, relationship stress, labor and delivery, or infant's health, unplanned pregnancy, or again, violence or an abusive relationship. And then in terms of how long it lasts, it says 2 weeks to a year or longer. And the onset may be gradual. So it may not be something that suddenly happens. It can be gradual. How often does major depression or postpartum depression occur? 1 in 7, like we said at the top of our discussion. And it says, so what happens with major depression? So change in appetite, change in energy, motivation, and concentration. They may experience negative thinking, including guilt, hopelessness, helplessness, and worthlessness. They may also experience suicidal thoughts and an evolution of psychotic symptoms, and thoughts of harming the baby. And then there'll be low self-care, so they really won't be taking good care of themselves.
That it?
Yeah, I was going to just talk about those two, but to add to that, we didn't really. So there's bipolar disorder. So there are all these disorders that someone postpartum is you know at risk for. So postpartum depression, perinatal anxiety disorders, schizoaffective and schizophrenia, and postpartum psychosis. An experience that I had with a client with postpartum psychosis, every time she got in the car with the baby, she wanted to drive into a tree. She heard voices telling her to drive into a tree. Borderline personality disorder, post-traumatic stress disorder, and obsessive compulsive disorder. So even just having these constant thoughts of, that something may happen to the baby, that could fall into that OCD category, or constant thoughts, kind of obsessive thoughts of harming the baby, things like that can fall into that OCD category. In terms of PTSD, so imagine if something traumatic happens to me, like we talked about some of the things that occur during pregnancy, right? So I may develop PTSD because of those things. And I'll let someone else speak.
I think that is very valuable information, and thank you, Dr. Callins, for dropping some more information into the chat. I hope that everyone will be able to hold on to the chat or copy some of the things out of the chat that are there. Did anyone else want to address this question? I'm sitting here thinking, wouldn't it be a wonderful world if we could live in a place where when a family is expecting that, we could wrap all these things around them and they could just be stress-free for that 18 months. Okay, all right. That's an extended period of time, but at least for 9 months, right? Or 10 months. I think it would just be awesome. It would not only, significantly benefit the well-being of the mom, but just think about the baby. I'm listening and thinking about how moms who experience depressive episodes and it's extended, how they disconnect from their baby, not intentionally, but because they don't have the capacity to care for the baby, and how that can impact the baby's long-term ability to have a secure attachment. And it will definitely impact the way they have relationships for the rest of their lives. So so many. It would just be awesome if we could create this bubble, maybe, where when a couple is expecting it, we could just make things as comfortable as possible. I know that can't happen because we got a lot of people having babies. But if we tag on to Pat's idea of a village, and it does take a village to raise a child, it takes a village to nurture a family, right? And if we buy into it and we can create these villages within our own communities and maybe have these places everywhere we need them. Did you turn on your microphone, Dr. Callins, because you wanted to
I
add?
did. I wanted to just share the importance of, so if I have a patient that I'm concerned about, I usually will administer the PHQ-9. I put this in the chat. I'll do the GAD-7 for anxiety, the PHQ-9 is for depression, GAD-9 for anxiety, and I'll do the MDQ, which eliminates post-bipolar disorder or evaluates. And I found that very important because you may think it's just depression and you give the patient medication and they don't do better, they don't improve. And so there may be something else. And so I'm not trained in psychiatry, but the pandemic forced a lot of people to do a lot more mental health because we were it for frontline for patients. And so I usually administer those three things and then have been able to kind of parse out kind of initial therapy, and then I can make a referral. Having access to resources is really important. But a lot of that I learned through working with Peace for Moms, which I put in the chat, which is a service line that's available in the state of Georgia out of Emory. So any provider can call that line if they have a postpartum patient they're concerned about. And within 30 minutes, somebody will call you back and they will either be able to give you advice or help you direct you to resources, or now they do have telehealth available. And so when you're working in rural communities, which I do quite a bit, you may not have ready access to someone that can help your patient. And so being able to triage that situation is really important, but also being able to do those screeners. And patients are really good about filling out screeners. The other point I want to make is, the postpartum period is not like a 6-week thing only. Like we have this number in our head and it really is not appropriate anymore. The new ACOG recommendation is a 3-week check-in. And then based on what's going on with the patient, if they have preeclampsia or they had a C-section, you probably need to be doing weekly checks. They don't always have to be in person. It might be telehealth. So really assessing the patient each visit, because they may have been fine last week, but I guarantee you this week it may be different. So if you only work off your previous assessment, you may miss something. And then if the patient has like they answer no to everything, like the 2 questions on the PHQ, but they don't look right. And this is what you're saying, Patricia, like your gut, like they look gray, like there's this like look. And so you may have to not always follow the screener, because they may not trust that if they tell you, are you going to like report them, or are you going to call DFACS, or like who are you going to call, or just there's all this stuff that may prevent them from being completely honest with you. And so keep in mind, you don't win all your battles the first time. So they may look great, but they don't respond to you appropriately. And so you kind of say, okay, we'll follow up, call them again, and you be persistent so they know that you really, really care. And then you may get more out of them with time. And so administering the questionnaires are important, but also repeating them is important. and then knowing when to throw them out the window if what you see and what they're recording do not add up. And so that just takes time and persistence. And I admit that in our medical community, everyone is so busy, honestly. And so that's why now a lot of times we're trying to encourage our pediatricians to help us with that, because the mamas may not take care of themselves, but they're going to the pediatrician, that baby. And so the pediatrician may see them. And so you want the pediatrician to call you and say, hey, I saw this mom today. The baby is thriving, but the mama looks crazy. Her hair's not combed. Can you check on her? So it's that, again, that village, that community where we're using all our available opportunities to really observe what's going on with mom so we can get in there and rescue her if she really needs it, but she's just scared to say that.
And I'd like to, I'm going to share my screen. Let's see. So screenings, so kind of piggybacking on what Dr. Callins said, when should screenings occur? So the initial prenatal visit to identify onset before pregnancy. So that's, so as when you first find out you're pregnant, when they screen you, then it kind of looks for pre-existing conditions, right? And then the next screening should occur in that second half of pregnancy to identify onset during pregnancy, because you could have developed anxiety during pregnancy or PTSD during pregnancy, right? And then the final screening at the end, at the postpartum visit or the fourth trimester to identify onset of late pregnancy mental health issues or early postpartum.
All right, thank you very much, all of you. I'm going to move to the next category of questions. And some of these, as I look at them, you all have already answered, like what resources and support systems are available for women who are struggling. I know in our community, they're probably few and far between. Here's one that I think what might be, how effective are treatments that are used with folks who might have experienced postpartum depression and are in recovery? Anybody think of anything that's, or treatment or medication or types of therapy? I know there are therapies for people who've experienced postpartum depression, but anything else?
I can share my screen again. Let me pull that up. And all right. Sure, that's the correct screen. That one. Okay. All right. So types of therapy, dyadic therapy for mother and baby, individual therapy, medication management, group therapy. I have medication management twice there. Cognitive behavioral therapy, interpersonal therapy, and dialectical behavioral therapy. And so let's see, I'm going to share again so that you can see another slide. All right, and let's see. Dyadic therapy. I had never really heard of it. And maybe with the population that I work with. And I'm interested if Dr. Callins and Pat have heard of it, because I'm thinking it kind of falls maybe Pat's realm, or Pat may have heard of it before. But so dyadic therapy, the goal of the intervention is a supportive relationship-based mother-infant psychotherapeutic component and developmentally based infant-oriented component designed to enhance maternal sensitive responsiveness and promote positive mother-infant interactions. Three main focus areas are maternal emotional well-being, functioning, and adjustment to motherhood. Infant behavior and development, getting to know the infant and the mother-infant relationship. Maternal sensitivity, mother's acknowledgement of the infant's interactive signals, joint attention with the infant, appropriate range of effect, positive effect, elaborating, expanding on infant communications, warm vocal quality, affectionate touch, resourcefulness in dealing with the infant's negative states, and consistency of style and supportive presence. When I think about consistency of style, if I have a mood disorder, or, just changes in my own mood, that might not, the baby needs me to be consistent, and it may actually, it will impact the baby. Um, um, Continue on with dyadic therapy, infant involvement, engagement includes the infant's gaze, joint attention, positive affect, vocalization, initiation in interaction with his or her mother, and alertiveness. Dyadic reciprocity includes relating to the infant and maternal reciprocity, adaptation, regulation, and fluency during the interaction. The one that you hear of the most is cognitive behavioral therapy. So it's an evidence-based form of psychotherapy with demonstrated effectiveness for various mental health conditions. The therapist and the client work to change thinking and behavioral patterns by focusing on the person's current life circumstances. CBT is not appropriate if the client is experiencing gender-based violence.
So I want to speak a little bit
Yeah.
to the dyadic therapy. And so one of the dyadic therapies that I am trained in and I use is called child parent psychotherapy. And it's designed to be used with infants, newborns, and their primary caregivers. And so most of those things that you identified are what they call serve and return. So, we ask, we help moms to become familiar with the number of cues or how their babies are sending them messages, and if and following the sounds, and playing with, and the importance of understanding that your emotional state is absorbed by your baby, and how important it is to do those things. It's a pretty well researched methodology, and it is also a long treatment time. It involves a minimum or like 16 meetings. So it is something that is highly recommended for, especially when there has been at least one traumatic event that the child has been exposed to, whether it is a medical trauma or something that happened within the family before or right after birth. I wanted to ask a question. I know that you have an intern there with you.
I do.
Does your intern have something that she wanted to add?
I wanted to share with Ms. Pat when she was talking about the baby and the mom and the crying and stuff. And I kind of went through something like that when I felt at that point with my last daughter, because I have two girls. One is about to be 10 and the other one just turned 5. But at the time when I had my then 5-year-old, 5 years ago, clearly, I dealt with, I would probably say more so between postpartum depression and baby blues, because it lasted longer than 2 weeks, but it was shorter than a year, if that makes sense. But I did go through that moment of sadness, and because I was dealing with a lot at the time. I was when I first got pregnant, I just found out my uncle had passed, so I was dealing with that. And then my husband and I were just got scammed out of a lot of money, so we were financially, so I'm like super stressing about that, and I'm like in the beginning stages of just finding out I'm pregnant. And so the whole time with that, I'm also just starting a graduate program um, at the time. So I'm like stressing about that. And then I eventually have my baby. And the first day at the hospital, first couple of days were okay. My whole, I want to say my birth, it was okay, but I remember because I ended up having a C-section with that daughter. Well, actually, I had it with both kids, but my second daughter, hers was scheduled. So I remember going through that process of um, them preparing me for the C-section, which was different with the first one because that one was an emergency. So that was a whole different experience. So this one was just, and I remember as we got through they were like, all right, we're about to go through the whole process of having the baby. And I remember crying because I was so scared. And I remember my husband was right next to me at the time, but I remember going through that whole process was just, to me, was traumatic because I remember it because I felt everything everything except for the cut part, but I felt everything. And I remember hearing, I don't know who said it, but I remember telling them I'm feeling away. And they were like, oh, you're just feeling pressure. And I'm like, kind of upset because I'm like, no, I'm telling you what I'm feeling. And this is what I'm feeling. Um, and one of the doctors or nurses, whoever, I don't know. And I remember hearing her say, well, this one didn't even want me to touch her. And I'm like, in and out of sleep, but that just kind of made me feel away, and it really made me like not want to have kids anymore because I'm afraid to go through the whole childbirthing experience. And I'm the type of person that hears something that happens to someone else and automatically internalize it to myself. So throughout my pregnancy, I did have experienced a lot of anxiety. I remember like in the beginning parts, okay, I found out I was pregnant, so I took pregnancy tests, and I remember I've seen some spotting and I'm freaking out. And I'm like, telling my husband, we got to go take another test because I need to make sure I'm still pregnant. And I've never dealt with, um, a loss or so, but I just, anything could happen. So, and I'm like freaking out during that time. And I'm like, we got to take another test. He's like, you're fine. You're still pregnant. But he went and got it for me just so I know I'm okay. I'm still pregnant. And then even the first week, my mom was there, my dad was there, and everybody was there. And then I remember the first day I came home from after having my daughter. And I came in, I'm in the house and I'm sitting down on the couch and my dad's next to me. He's talking to me. I guess he asked me a question. And I think my husband said something to me, and my daughter, I have, at the time, my oldest one was like 5. So she's just kind of, running around the house. And then my mom's in the kitchen cleaning up. And it just felt like everybody just kept saying something to me. And I remember like I'm trying to hold it in and I just burst into tears. I don't know why, but I just burst into tears. And my mom comes and gets me and she's like, comforting me. And she's like, it's okay. You're dealing with postpartum. And I didn't deal with that with my first daughter. And I don't know what it was with the second one, but that's just what I was experiencing. And then I remember when my mom had left, my dad was still there for a little bit, but my mom had left, and I remember crying all over again. I'm like, I don't know if I'm crying because she's leaving or what it is, but I'm crying again. And then my dad left, and I cried again. And then I remember I'm in the kitchen and I'm putting up dishes, and I'm just, I think at the time my daughter was sleeping or so like that. And I remember I just burst into tears all over again. My husband comes and he takes the dishes away from me. He puts them up and he just guides me to the room. And I just lay down and I'm just crying. I don't know why, but I'm crying. And I dealt with that. And then I remember I ended up having to go stay in Atlanta for like a month or so. And I don't know if it was because I wasn't back in my house and I always felt, well, maybe I didn't have the support because I had my sister there, I had my aunts there. But I remember just trying to hold it in, but I just kept crying. They were like, what's wrong? I said, I don't know. But I just kept crying. And it was very hard for me to deal with the pregnancy because also I was trying to breastfeed and that was hard. And I was stressing about that because I didn't really get to do it that long with my first daughter. So I'm like, I want to make it right for this one. And I struggled with it then. And then I it was still in school at the time. So it just felt like a lot that was on my plate. And I don't know, that was just my experience with dealing with it. And I didn't really talk to anybody about it. I don't know how I got better. I don't know. I couldn't tell you, that was so long ago, but I just remember it was so hard for me. I felt it was hard for me to bond with my second daughter because I was like, I don't know. And she kept crying. And I remember oftentimes I would have to give her to my husband because I was like, I can't deal with this right now. And I'm trying to feed her. Like, I went through nights, me and my sister, and we're passing her back and forth because she's hysterically crying and I'm trying to breastfeed her. And I'm like, she don't want the breast. I can't give her the breast. And I'm crying all over again because now I can't I can't provide for her. So it was very hard for me. It really was with my second daughter. It was very hard for me to really try to connect with her and be that mom. And I did get to a point where I was like, I can't do this. I just can't do this. And I remember times I would have to walk away and my sister, and I felt bad because I'm like, now I'm leaving my baby with somebody else to care for, but that's my child. But right now I can't deal with her because I don't want to, hurt her because I'm so frustrated, because I'm so mad. So that was just my take, my experience.
Wow, thank you. Thank you so much being willing to share that
Thank you.
with us. I know there are probably lots of moms out there who need to hear your story. Thank you. Thank you so much.
No problem.
Okay. Yes.
Can we talk about breastfeeding just for a quick second? Because I think that you mentioned some really important things, and I wish that you could hear when that was going on. You're not a bad mom if you can't do that, or if you can't do that right this second. And I remember I struggled with breastfeeding when my first actually was an exclusive pumper because my son just would not latch on. So he got the milk, but just not directly from me. So being able to adjust what you're doing, and I know Patricia can speak to this, but I know I felt bad because I couldn't do that. And so, as we are working on we use the term now lactation and infant feeding a lot. So that way, in the event that something has happened, let's say you had a breast reduction and you can't make milk, you don't feel bad because you can't. And so we're changing our terminology about how we talk to moms about infant feeding, because sometimes it works well, and sometimes we can help you get it right. And sometimes we do everything and we move the mountain and it still does not happen. But that does not take away from what you can do as a mom. And so being able to make sure that we're not feeling ashamed because we can't do that thing. And you may have breastfed with child one, but child two does not want to do that. So really having that supportive community. And the one thing that I didn't hear from you is, I wonder, who was in charge of your care and how did you interact with them? And did you have a doula, and did you have support, and, a lactation consultant and all of that? And so again, resources. And so really that information needs to be provided to our patients in the prenatal period before you have the screaming baby. So you have your dial-up numbers. If this happens here, I'm going to do X. And so I think sometimes we can anticipate and plan for those things. I came across a website recently that I put in the chat that talked about a postpartum vision board, which I think is like awesome. It's like, what do you want? And if it doesn't happen, then who are you going to call? And I can tell you those breastfeeding issues happen at 2 a.m. Who is up at 2 a.m.? You probably call Miss Prime. She'll probably wake up for you. But my point is, like, who's going to be your backup? So how do we build that, dial up emergency SOS 911? But we have to remember that our moms need to hear those positive things, because you're responsible for our whole life. Like, they sneeze and you're like, what's wrong? And that's a big deal. And I don't know why you were crying, but I kind of know why. It's overwhelming. I put in the chat the Barkin Index for Maternal Functioning, which I think is a great tool for us to look at, because not everybody feels like throwing their baby out the window, but you just feel like you just cannot handle it. And a lot of times it's temporary, right? Because you did get better and you don't even know what made you feel better. Sometimes it's transitional, it's hormonal, it's situational, maybe people related or not. And God forbid you don't have a supportive mom or dad or sister, or you're somewhere where you're not supposed to be, you delivered unexpectedly and you don't have your family. So how do we really build that village wherever you are. And because of the internet and all of our technology, we can do a better job of that now if we know that. But we don't want you to be searching through. That toolbox should be built before that baby comes out. And because babies can come early, that toolbox really needs to happen right about 28 weeks. Because after that, things may or may not go like you planned. So you don't want to wait to pack your baby bag the last minute, right? Like I tell my mamas, is your car seat by the door? Is your bag by the door? So your toolbox really needs to be designed in about 28 weeks, 7 months. And that way you kind of have that action plan ready to go. And so I think as a village, we can do better about that. And a lot of people don't live close to their family anymore. Like when I had my kids, my dad was in Jamaica, my mom was in Florida, my in-laws were in Birmingham. I didn't have that close. So I had to build that. So I was in training. So the nurses at the hospital were my support system because that's where I was all the time. So, but I just wish, if you do have another baby, if you decide to do that, because 5 years you're on a roll. So another 5 years we're there, how we build that toolbox for you early in the process, I think is a game changer, because you may still have those feelings, but at least you'll have that number to call if you do feel that way.
Awesome. Wonderful, wonderful advice. Prevention is so important. Prevention is so important. So we build our tool bag. Am I talking to myself? Okay, sorry. I thought that I was still on mute. We build our tool bag before we need it, and then we are ready to build an awesome house, right? I have one more question I'm going to ask. I think there's just one. And this question is about promising new research developments related to PPD prevention or treatment. Anybody have any input on any new research that's out there? Looks like Dr. Callins just put another link in our chat. There is a whole website on perinatal mental health, a couple of them where we can identify research and articles, but I think that even though the information has probably been happening around the country for a long time, it is finally getting to Georgia, and we're all working across disciplines. Right, we should be working across disciplines and talking to everyday people about the importance of this whole taking care of mom, dad, baby, family during this entire perinatal period. And I'm sure there's lots of research that supports, us being able to, or us taking advantage of the fact that we don't have to wait. We can start taking care of people. And we should take care of people across that whole phase. Okay, so
Can I
no
say
response. I'm
Oh.
sorry.
I'm sorry, I thought you were finished.
I am done. I was going to ask another question because it was quiet.
Oh, but can I just say something to the research? Research shows that doulas can decrease cesarean births. They can increase breastfeeding initiation. They can increase a mom's chance of giving birth without the use of a lot of medication. They can also contribute to a decrease. They can decrease the chances of that mom having postpartum depression after the birth of the baby. But I feel like in our community, in the rural community, things that are south of Atlanta, because we don't understand, I don't believe that we are even aware that we are in a maternal health crisis.
Mhm.
I believe that in our community, we are used to the care that we are given when we enter into the healthcare system as a pregnant individual. And that care that we get, we believe that is the care that we are supposed to receive. So when I, for an example, would say, I am a doula, I can assist you, I'm kind of met with resistance, but not because they don't want me. It's because they don't understand what we can bring to the table. That's one thing. The next thing is the price. So there are some insurances that are starting to cover doula support, but they are only covering the labor doula. So because I am just a postpartum doula, insurance companies will not allow me to be a provider because I'm not a full spectrum doula. So that will cause some families not to be able to afford to have a doula to support them. The reason I'm bringing this up is because if we keep putting in the faces of individuals that doulas can do this, doulas can do that, doulas, and they can't afford a doula, and the insurance company is not covering the doula, we have now put another barrier in front of that mom that puts her at risk for all of the negative things that we just said. Until we are aware that there is a maternal health crisis in Georgia, and not just in Georgia, but in the North Central Health District in which we live, we are number 2 in the state for the worst maternal mortality rates in our area. If we don't understand that as a community that we are at risk for moms dying, we will never be able to put into place the things that need to be put in place in order to keep our moms safe. We cannot do this in silos. The hospitals cannot do it by themselves. The doctor's offices cannot do it by themselves. Doulas cannot save lives by themselves. We have to do this as a collective, collaborative purpose in order to start saving our moms' lives. We got to stop putting the Band-Aid on. Oh, a doula will help you. We have, let's just talk about racism. No, we have to talk about the entire system in order to start making some waves in this area. But first, we got to understand that we have a maternal health crisis in our community, not just Georgia, but right here in the North Central Health District, Middle Georgia area.
Mhm, mhm. We do, and you're absolutely right.
Well said.
There has to be some advocacy. There has to be, we have to kind of see what's actually happening, and too often we don't pay attention because we hear about that one mom who died in pregnancy or that or whatever, and we think that's an isolated situation, but we know it's a public health issue, and but all of us need to be talking about this public health issue. All right, Miss Tisha has joined us. So that says that we are winding down in our time to talk, y'all. This has been a wonderful conversation. Thank you all very much for what you've added to our knowledge base so far. And during this conversation, thank you so much for your time this evening, for all the work you do with the moms and children out there in our communities. And I'm just extremely grateful. I know that everybody else is who's listening, who invited you. So I'm gonna turn the microphone over to Miss Tisha Davis.
Greetings. I am Link Tisha Davis, Chair of the Health and Human Services facet. The Macon, Georgia chapter of the Links Incorporated are grateful you joined us tonight to become more aware of how postpartum depression impacts women's, moms, dads, and babies' mental health. Dr. Cisse, Dr. Callins, Therapist Craig, Nurse Lynn, Nurse Prime, and Therapist Craig intern. Thank you for sharing pertinent information about the research and your personal experiences. Audience, you've received a wealth of information from this expert panel. If you, family, or friends inquire about postpartum depression or exhibit any type of depression, please don't hesitate to reach out to your mental health expert, your medical provider, your OBGYN, or reach out to a member of this expert panel. Again, thank you to our expert panelists. Thank you to our viewers. Please share the knowledge and let your friends and loved ones know that they are not alone. Lastly, this is Mental Health Awareness Month, and we are in voting season. If you have not previously voted, please go out and vote tomorrow. Thank you and have a good night.
Thank you. Good night.
Good night.